Thank you very much. I had to switch because I prepared an hour lecture, so I had to give now a 25-minute lecture. So what I'm going to talk to you about, basically 60–70% comes from cases that I've seen personally or have had in consultation. And I do this because I'm going to try to give you a very practical approach to some of the very difficult problems that we have with regard to these different lesions. So the first is the spitz nevis, which the classic, Clay has been talking about this. This is a classic picture of a spitz nevis. And I'm still recovering from an injury in an escalator, so if you don't mind, I'll sit down giving the talk. So this is a classic picture of a spitz nevis on the face of a child. Now, clinically, one of the very important aspects of the spitz nevis is that it has a peculiar phenomenon of presentation. There are two melanocytic lesions on the body where the patient will say, this came rapidly after I was in the sun on the beach or something. Or someone will say, this lesion came near my birthday. The spitz nevis and nodular melanoma are the two lesions that have this very characteristic history. Unfortunately, it doesn't help that much, but in a child, you will consider mostly to be a spitz nevis, and the color can be anywhere from flesh to red to brown to black. And this is a classic histology of a spitz nevis, which I emphasize because I'm going to talk about variants of it. The spitz nevis, as you can see, is associated with a proliferation of cells that form an inverted triangle. And we thank Bernie Ackerman for this observation. He was the first one to actually point this out, that you have the base of the triangle all along the base of the epidermis, and the apex is down into the dermis and sometimes into the subcutaneous fat. The cells, as we know very characteristically, are arranged superficially in nests, break up into smaller nests and single cells. When they are spindled, they run parallel to perpendicular to the long axis of the epidermis, and the cells have a striking morphology. The spitz nevis cells by nature are atypical. They include giant cells, they include pleomorphic cells, but there's a background of uniformity to them that helps you in making the diagnosis. So classically, the spitz nevis will show superficially large nests of cells. In the depth, it breaks up into single cells, and they infiltrate amidst the stroma. Now, this is a poorly fixed section, but Dr. Elston Hellwig years ago emphasized that the picture of a spitz nevis, the cells look at home in the dermis. Now, we know today why that is. Melanoma cells produce metalloproteinase and digest the collagen and hence cause a disruptive picture, whereas spitz nevis cells are like fibroblasts. They sit at home in the dermis. So clinically, they are characteristic on the face of a child, rapid growth, dome-shaped papular nodule, pink, tan, or red color, but they can be black. Epiluminescence microscopy has a specific picture, and the architecture we've described. So that's a typical spitz nevis. Now, what is an atypical spitz nevis? This is an example. Clinically, the atypical spitz nevi are usually larger than the normal nevis, but not always. But you see, rather than having large nests breaking up into single cells, these are very large expansile nodules. That is an atypical feature, and on high power, you can see that they are composed of spindle cells in different angles of orientation. This is another example of something that diagnoses an atypical spitz nevis. Now, follow-up in these two patients is over 10 years without recurrence. This is a lesion that has an architecture of rather a rectangle rather than a triangle. And as you can see, that it does reach down into the dermis, but it is associated with marked epidermal hyperplasia. And when you look at the lesion closely, the cells are classic spitz nevis cells in a raining down pattern. And at the depth of the lesion, the cells break up into single cells and extend into the dermis in this manner. But the pattern and the cellularity would result in my calling this an atypical spitz nevis. So usually they consist of expansile superficial nodules with asymmetry, impaired maturation often, rare dermomitoses. These changes as single features would prompt the diagnosis of an atypical spitz nevis. Now then we go to the atypical spitz tumor. So I'm gradually going through this with you because now my talk with emphasis is going to be on childhood melanoma and how you diagnose childhood melanoma. So the atypical spitz tumor has been divided by Alan Spatz and Barnhill, and already in 1999 into very interesting conclusions. Number one, the age is usually greater than 10 years. That is not true. However, in their series, the age was greater than 10 years. These can occur in children, and there are cases seen as early as 3 to 4 years of age. Ulceration. Ulceration is true. It used to be taught that spitz nevi ulcerate. Spitz nevi that ulcerate are atypical. Involvement of the subcutaneous fat. That is very important. Now, what we mean by involvement is not single cells infiltrating the subcutaneous fat, but nodules of cells infiltrating the subcutaneous fat, and a mitotic rate of greater than 6 per millimeter squared. Those are features that are characteristic of the atypical spitz tumor. Now, looking at this is completely different than anything we've seen so far. And you can see this is a sheet of proliferation of cells that extend downward and bulge into the subcutaneous fat, replacing it. In fact, that is completely different than an atypical spitz nevis or a spitz nevis. So here is the cellular growth, which is expansile and destructive, and that is associated with marked hypercellularity. Now, there are many lymphocytes in this as well, but I draw your attention to something that's often very helpful, is the presence of multinucleate giant cells. If you're looking at a lesion, you're looking for spitz. Of course, this could also be in a fibroxanthoma, but in the background of a spitz, this is very helpful at times in making the diagnosis. So the atypical spitz tumor differs from the spitz nevis in the following. Size, less than 1 centimeter, the spitz nevis, greater than 1 centimeter, the atypical spitz tumor, a symmetrical lesion versus asymmetrical, sharply demarcated, poorly demarcated, regular nesting, irregular nesting, no deep extension other than a few single cells at the most in the subcutaneous fat, deep extension, and no expansile nodular growth, expansile growth present. So that is to differentiate a spitz nevis from an atypical spitz tumor. Now, there is a variant of melanoma that is called the spitzoid melanoma. It is a lesion that occurs mainly in young persons, and it is usually in the head and neck region. And the differential diagnosis is a high-risk atypical spitz tumor. The consensus on this, it's a rare lesion, is that biologic behavior is unpredictable. Longer-term follow-up may reveal a clinical course no different than other types of melanoma, but the lesion is a very striking one. It is predominantly dermal-based, expansile nodule with variable permeation of the subcutis. Numerous bizarre-appearing giant cells, similar to those in the spitz nevis, but with much greater pleomorphism and nuclear atypia, and sheet-like growth with atypical mitoses. Now, this is an example of a spitzoid melanoma. This patient is still alive 7 years after this diagnosis. This is our called 9-year-old. With striking intraepidermal involvement, but it's predominantly dermal-based. As you can see, it is composed of multiple large nests of cells. Now, there are several things about this that are interesting. One of them is that you see foci of pigmentation. Here are pigmented nests compared to these that are not. This type of isolated areas of clonal pigmentation usually is associated with aggressive behavior. There is a striking inflammatory infiltrate also associated with this lesion. And this is the type of pleomorphism you see in the spitzoid melanoma. Now, I emphasize this picture to you because you see very large epithelioid cells with very hyperchromatic, very unusual nuclei, spiculation of the nucleolus, the very unusual giant cells with almost a half of a wreath here, and this is another portion of a giant cell. So very striking pleomorphism. But you notice that it has a spitzoid quality to the cytoplasm. It's a hyaline, bluish-based quality to the that you see in the cytoplasm. Looks much like a spitz-like lesion. Melanoma cells in the cytoplasm usually have very fine granularity, or Philip Lebois refers to it as dust-like, or he calls them pulverocytes, that they have dust in them. Spitz nevis cells have a hyaline cytoplasm. That's different as we'll see. So what there are, as Clay has already said, studies by fish which are useful. We use the fish routinely for problematic lesions. We do not use any special stains for diagnostic lesions, but where problematic lesions, we'll use the fish technique. And anyhow, it is interesting that there have been found by the comparative genomic hybridization and 102 spitz nevi studied for the 11p copy number increases in fish. Now it's interesting that the mutation in the spitz nevis is a RAS mutation, whereas the mutation in melanoma is BRAF. This is a RAS mutation. So anyhow, 11% of these lesions had 3 times the copy number of the 11p. Now 11p does not occur in melanomas, or it is not one of the findings in melanoma by CGH. So what about childhood melanoma? This is described generally as patients less than 20 years of age. That account for about 1.2 to 2% of all cutaneous melanomas. They're present in prepubertal children, comprise 0.3 to 0.4% of cutaneous melanomas in general. 33% of prepubral melanomas arise in giant congenital nevi, with 50% reported in the first decade of life. A study of the SEER database reveals 44 to 65% in tumors in young melanoma patients were diagnosed of tumors of uncertain prognosis or borderline lesions. I will tell you that I do not use the term meltump. It's become a wastebasket term. It was a very useful term in the beginning, which was for very large expansile nests that are very cellular. Now people are even using it for some of the more superficial lesions. What I do in my consultative practice is I will say this is a lesion I consider at low risk for metastasis or at high risk for metastasis. And then the clinician can act accordingly with that. But most times pathologists will tend to use terms that are waffling a bit in the children's lesions. Now the survival is very interesting. All patients with metastatic melanoma arising in giant nevi were dead within 5 years in a study of Trozac, the only large study actually of melanoma in giant congenital nevi. Patients with melanoma arising de novo, including small congenital nevi, had 34% survival at 5 years, and the survival of congenital melanoma is poor. I have only seen 2 cases of congenital melanoma, both were on the scalp, and both children died. Now, what are the risk factors for childhood melanoma? A history of dysplastic nevus syndrome, xeroderma pigmentosum, and the giant congenital nevus, or bathing trunk nevus. This is from a series by Science in 1999. There's a recent series by Messina in the last 2 years, which shows essentially the same type of picture with regard to stage 1 lesions, stage 2 lesions, stage 3. The greater the stage, the more the mortality, as you can see clearly here, and tumor thickness is related to directly the patient survival. The thicker the tumor, the greater the risk of metastasis. Now, disease-free survival for sentinel lymph node positive adults and pediatric patients together were described in 2005, showing this was the sentinel lymph node positive ages 12 to 20, sentinel lymph node positive ages greater than 20. So better survival in patients who were in the 12 to 20 year age group. Now, about 5 years ago, I was asked by USCAP to give a talk on childhood melanoma. So all the recent papers that you will read that have all come out in the last several years all have a spectrum of survival. So I decided that I would call around my friends worldwide, literally, and ask them for any children, they had the histology on children who died that were younger than 13 years of age. So for me, childhood melanoma is in prepubertal children, all right? So I got 18 patients. Now, these are not some of those patients. I'll show you one of them is someone that was on these patients. This is a congenital nevus that arose, a melanoma arising in a congenital nevus. This was a lesion in a 14-year-old boy who, as you can see, was very sun sensitive. This lesion was treated as thought to be originally some type of hemangioma. This is another congenital nevus with multiple small congenital nevi with a very large malignant melanoma that was also associated with melanosis, the meningeal melanosis. So what about congenital nevi? The approach to them is divided. For example, in Germany, any giant congenital nevus is removed. They will remove them in the first 2 years of life. In our clinic, we treat each individual separately according to the lesion, the atypia in the lesion, the characteristics of growth, and so on. But congenital nevi that are tranquil, without multiple nodularity and so on, we'll usually follow. This is another boy that this boy presented at 13 years of age, but he had this lesion on his scalp for over 4 years, and he went on also to die. Now, this is a very important picture. This is a patient that I myself saw. This patient had been treated for a wart first time. It was biopsied and showed dermal nevus. It recurred and was questioned epidermal nevus. And this was the third time when she presented actually with this lesion, with now had a nodule in it, which was a melanoma. She died at 18 years of age. My message with it is very important. When you have a biopsy of the scalp and you think it's a nevus or a epidermal nevus, or you think that it's a wart, and it comes back melanocytic lesion, make sure they do levels and that you really follow the patient or excise the lesion. Because these lesions can present just like an epidermal nevus or like a wart, or sometimes as a nevus itself. But this child should not have died. It should have been diagnosed earlier on. So I will then present you the cases, some of the cases from the 18 I think that are instructive. This is a 13-year-old female. The primary tumor was 2.2 millimeters thick, Clark level 4, ulcerated with a mitotic rate of 3 mitoses per millimeter squared, located on the foot. Her lymph node was positive at the time of excision, and she died of metastatic melanoma 2 years later. And this is her histology. As you can see, this is the histology of a superficial spreading melanoma, and it clearly shows differentiation into a nevoid melanoma here, but then there are these foci or clonalities of pigmentation and varying nests opposed to those that are not pigmented. This is clearly a malignant melanoma and was diagnosed as an atypical spitz nevus. I don't know how that diagnosis came about, but that was, and this is showing you the multiple clonality that is a clue to melanoma diagnosis. And here are your pulverocytes, if you wish. The second lesion, a 16-year-old female, the primary tumor, a nodular melanoma, 10 millimeters thick, level 4, not ulcerated, 6 mitoses per millimeter squared. 1 month later, she had 11 of 17 lymph nodes positive and died 8 months later with metastatic breast. And this is her lesion, which again is a lesion, and these are histology that were sent to me, but these are lesions in which you have massive nesting of very atypical, very pleomorphic cells, and I think that without question, this lesion, look at the difference between these and even the spitzoid melanoma. The spitzoid melanoma is phenomenally pleomorphic. This does not show, this shows much more the pleomorphism and atypia of melanoma cells. So this was also a primary melanoma. The third is another nodular melanoma, not ulcerated. 2 months later had axillary metastasis, pulmonary metastases 4 months after diagnosis in an 11-year-old. And as you can see in this lesion, this is a dermal-based tumor. And it's a dermal-based tumor that shows you very hyperchromatic cells. Now this really resembles the pleomorphic spitz nevus or spitzoid melanoma. But with the mitotic activity and so on, this lesion should at least have been treated as a malignant melanoma. This is a 10-year-old female with a congenital nevus on the back that changed, who died of metastatic melanoma. Now this is fascinating, because here is your congenital nevus, here clearly, but here you see something different. And as you study this more, and as they did deeper sections, this area became more prominent with very large nests, And as you can see, this is the higher power of this particular nesting. And these are all melanoma cells with very striking granular pigmentation that were called a spitz nevus in a congenital nevus. And these clearly are malignant melanoma cells, as you can see here. And there's discohesion of the cells, hyperchromasia of the nuclei, there's dusty cytoplasm, characteristic melanoma cells. Here invading into the dermis and into the congenital nevus itself. This is now an 11-year-old boy, and this is a boy who presented to our pigmented lesion clinic. He had been followed for 2 years and was told that he had a benign lesion. The pediatrician followed this lesion for 2 years, and then finally, when this became very black and this changed, he sent him to the pigmented lesion clinic. This lesion was an extraordinary malignant melanoma. This is simply the reddish nodule, but as you can see, it is a pleomorphic spindle cell malignant melanoma, and that patient went on to die. The next is a 6-year-old girl on the upper arm, a 4-year-old girl on the upper arm, case 6 from our series of 18, the thickness greater than 8 millimeters, 8 mitoses with numerous marginal mitoses. Now, I wanted to bring up to you the issue of marginal mitoses. The marginal mitoses describe the mitoses in the 0.25 millimeters around the periphery of the nodule. That's the margin. That is very characteristic of lesions that metastasize, both in the atypical spitz tumor and in melanoma as well. So this patient had multiple marginal mitoses, had prominent intravascular invasion, positive lymph nodes, and dead within 4 years. This was sent to me also as a spitz nevus in consultation. And as you can see, there are multiple areas of striking irregular morphology. And look at the cells with the extraordinary mitoses even here in the margin. These are marginal mitoses, striking this cohesion of the melanoma cells, very striking lymphatic invasion, and this patient went on to die. Now, this is another interesting lesion. Is from the Mass General Pigmented Lesion Clinic, a 7-year-old girl, a lesion on the lower leg diagnosed in 1969, I think it was, as a spitz nevus. As you'll see, this patient first metastasized the lesion to, at age 11 to inguinal nodes, and then died of systemic metastases at 16. Now, what's wrong with this picture? Why is this not a spitz nevus? Because the apex is here and the base is here. This is the inversion of the spitz nevus. Spitz nevus, remember, the base is here, the apex is here. This morphology is either of an atypical spitz tumor or a melanoma. And I think this is, for that reason, very instructive. Here is your origin site, and as you see, it pushes down. This is another very interesting example of involvement of the subcutaneous fat that is very worrisome. When you see for example, in the combined nevi, you often see lesions go into the dermis, into the subcutaneous fat, along the hair follicle, but they go along as small nests. This is like a pushing fist, and that is a very abnormal and worrisome sign. And this is a picture of that, and you see how it destroys the architecture of the eccrine gland, which is very helpful in making your diagnosis. And this patient also had marginal mitoses, so she went on to die. And then finally is a 13-year-old boy. This is a boy who was kept in the closet mainly in his idea of being kept at home. His parents were ashamed that he had this mass on his scalp, and finally they brought him into the clinic. This lesion, as I showed you this before, this is his primary site, and when he presented, he had nodes as well. And this is another very strikingly, very pleomorphic lesion that is a spindle cell melanoma, as you can see, with dense hyperchromasia. You can't even see really the clear nuclear detail because of the dense hyperchromasia of the cells admixed with epithelioid cells. And notice these clear nuclei with a thick rim and multiple nuclei with thick rimmed chromatin and multiple nucleoli. And so this was another example of a melanoma in childhood. So what are the features associated with death? Large, bulky lesions that are deeply invasive, ulceration, extensive necrosis, severe pleomorphism, numerous dermal and marginal mitoses, definite intravascular invasion. Now, 14% of spitz nevi protrude into lymphatics, and as congenital nevi protrude into lymphatics. And you can easily document that by doing a D240 stain. You'll see that the lymphatic wraps around the nevus cells, whereas if in these lesions, which are true intravascular metastases, there is no D240 around the cells. The cells are nodules that are present in the vessel. Multiple positive lymph nodes in draining basin, especially masses of lymph node deposits. And this is very important. Deeply invasive small cell melanomas of the scalp. This is a really interesting melanoma, of which we had five cases at the Children's Hospital in Boston, and where I saw several of these cases. These children came in with nodules on the scalp. 3 of them were in a congenital nevus, and they were very small cell lesions, were thought to be maybe Ewing sarcoma, whatever. They turned out to be melanomas. Small cell melanomas of the scalp, all of them were into level 5 and were at least 5 millimeters in thickness, though all those patients died. So I think that the best way I can approach this for you is agreeing with John Kirkwood that we won't understand the biology of melanoma until we have 35 years of follow-up. The GEM study that Clay was referring to before has also shown, and SEER data, that recently that melanomas 0.3 millimeters thick have the same superficial spreading melanomas have the same rate of metastasis as melanomas greater than 0.75 millimeters, between 0.75 and 1. Melanoma still is a mystery. We're unraveling a great deal of it, but only with long follow-up will we understand really what is going on with these tumors. And this is an example of a study that I always like to show, and that is looking at mitoses, and this is from the group in Australia. If you look at and this is out to 15 years, and look at the very marked difference in survival with patients who had no mitosis compared to those that even had 1 to 4, and actually these all tend to end at the same. Now I'll tell you, I just concluded a study, and I'm finished with my talk, but just concluded a study of 1,280 patients with 30 years follow-up from the European, I'm a director of the pathology program of the European Organization for the Research and Treatment of Cancer. We had a multiple nation study, and it's very interesting that we found a dense, brisk host response has a favorable survival at 30 years, 96% survival. Non-brisk and absent both tend to be at the end at 30 years. That really has a much different interpretation than we usually give for non-brisk. For non-brisk, we say the survival is intermediate between brisk and absent. But when you have 30 years of follow-up, non-brisk is almost equal to absent. But dense, fully brisk lymphocytic infiltrates survive in 95% of cases at 30 years. That'll be published shortly. So my purpose was to discuss with you, and I wanted to thank these persons especially for their help with this. And I wanted to discuss with you the concept of the spindle cell lesion, starting with the spitz nevus as illustrative, and then going through the different morphologies, finally to truly childhood melanoma that kills children. The basic message is that in virtually every one of the 18 cases, if you'd said, look at this lesion, you would have diagnosed it as melanoma without batting an eye. You wouldn't sit down and say, oh, I think that's an atypical spitz lesion. When they kill children, they look like melanoma. So I think that's an important message to take away from the lecture. Thank you very much. Are there any comments or any questions? Yes.
My name is from Budapest, Hungary, and I want to congratulate to your wonderful data. And my question is, how much could you benefit from dermatoscopy in the diagnosis?
Okay, that's a